Hello, and thank you for joining our webinar. My name is Amy Swanson, and I am a genetic counselor with Illumina's Medical Affairs team. It is my pleasure to introduce our speaker, Dr. Glenn Palomaki. Dr. Palomaki is a professor in the Department of Pathology and Laboratory Medicine at the Women and Infants Hospital of Alpert Medical School at Brown University in Providence, Rhode Island. He is an expert in prenatal screening with over 250 peer-reviewed publications and was a principal investigator on the first external clinical validation study of non-invasive prenatal testing. Today, he will share with us his expert opinion and findings from his recent clinical utility study on NIPT in the general pregnancy population. Dr. Palomaki, thank you for joining us.
Well, thank you for the introduction, and I'd like to thank Illumina for inviting me to give this webinar. So let's get going. First, a disclaimer and disclosure from Illumina, and I'll just point out the third bullet is, all of my honorary and whatever goes to my institution. Somewhere it disappears in the hospital. So my majors are, I am an employee of Women and Infants Hospital, Rhode Island. I have received industry-sponsored grant and research support, as was said earlier. The Sequenom study published in 2011 was the first external validation study. The DNAFirst study, which I'll be talking about more today, was funded by Natera, and that was a general population study with counseling provided by primary care providers, and we're in the process now of doing a study with the value study with Perk and Elmer, which is a lower cost method of doing sequencing. And they're the rest of my disclosures. So let's start off outline just for those of you who might not be too familiar with the topic. We're just going to start off with a very brief introduction to cell-free DNA screening for common trisomies, look at some of the older and then more recent relevant professional guidelines. Then high and low risk populations, screening really does have some differences in those two populations. And then the last two bullets will go into some of the findings of the DNAFirst study that was published in Genetics and Medicine in 2017. So here's a little introduction. First, you'll notice I tend not to use the terms non-invasive prenatal diagnosis or non-invasive prenatal testing or non-invasive prenatal screening. As you know, this test is different from the combined test or the integrated test, which look at phenotypic markers. This cell-free DNA is actually looking at genotypic markers. So it was originally thought that, this might be diagnostic, and NIPT is the holy grail of can we create a diagnostic test for the fetus without doing an invasive procedure. But that's not true. We know that now. So it was changed by some people to NIPT or NIPS, but that's really not descriptive. Ultrasound serum screening, a combined test, an integrated test, a quad test are also non-invasive prenatal testing or screening. And I just give a couple of examples here. A lot of you just know neural tube defect screening as AFP screening. But you see, if you write out kind of what's the test and what's the disorder, it becomes very unambiguous what you're talking about. Prenatal screening for open neural tube defects using alpha-fetal protein, or second trimester screening for structural, second trimester ultrasound screening for structural defects, blood pressure to identify hypertension, and so on. And so what, a nice short way of saying it, which is unambiguous, is sequencing cell-free DNA to identify common aneuploidies would be a good descriptive term. So you'll see me just call it perhaps cfDNA screening. So the original finding of this circulating cell-free DNA was by a group in Hong Kong. Dr. Dennis Lowe had been to a recent talk on cancer where they were talking about circulating cancer cell-free DNA, tumor DNA, and he said, well, the fetus is somewhat like a tumor. It's a different material. There should be fetal material circulating as well. So he did a very simple experiment where he took both maternal serum and maternal plasma, ran an electrophoresis on a Y chromosome probe, and it turns out, there we go, that The males all showed the SRY probe, the little line there under the arrows, and the females did not. Not all the males did, because there really wasn't much DNA in the samples he had, but no female had that line, and the majority of males had that line. And his conclusion was that there is circulating fetal placental DNA in the maternal circulation. Things that we now know: there's not only cell-free fetal DNA, but there's also cell-free maternal DNA. It's a mixture. The fetal DNA, though, is a misnomer. It really should be called placental DNA. So as soon as I tell you it's placental DNA, you should all kind of think, oh, that makes cell-free more like CVS than an amniocentesis, because the placenta is almost always, but not always, the same as the fetus. It's also quite chopped up. The DNA is actually 150 to 200 is kind of where the peak is. Probably 90 to 250 are the base pairs that are in circulation, and they do represent the entire genome in proportion. So there's for the size of chromosome 1, there's the right amount of circulating DNA to represent chromosome 21, and so on and so on. Now, fetal DNA, again, I'll say fetal, but you have to in the back of your head say, he should be saying placental, but no one does, is about 10%. And to put that in context, when people were looking for fetal cells 20 years ago, they were talking about 1 in a million, 1 in 10 million. Here we're saying that if you pull out 10 fragments in the maternal circulation, one of them is likely to be from the fetal placental unit. All right, so here is, it's an odd way. You probably haven't seen it shown this way before, but you see the overlapping distributions. You may have seen this, for example, for AFP and neural tube defects, where there's still a reasonable amount of overlap. Even if you had an integrated test and you had risk across the x-axis, there's still a reasonable amount of overlap. This is the chromosome 21% in euploid and Down syndrome pregnancies. And if you see the little dotted line, you say, boy, that dotted line is kind of going where a cutoff might be, but there sure as heck isn't much overlap there. They look pretty distinct, almost. Well, if they were completely distinct, you would have a diagnostic test. But there still is some overlap. And there's a second reason it's not diagnostic. There's something better. An amnio and a karyotype is still better than this. So it's not a diagnostic test, but it's a very, very good test with a very high detection rate and a low false positive rate, but some failures, and we'll get to all those things in a bit. There have been a couple of high-profile observational studies that kind of confirm that cell-free DNA in a larger population has the characteristics that we think. In the left-hand figure, you'll see the false positive rate, and you can barely see the little green rectangle down there at a 0.25% or so for cell-free DNA. A 0.25% is 1 in 400. Whereas the combined first trimester test, which is, NT-PAP-A and HCG or free beta, has, 3-4%. And this study showed that those two are quite different. 3.5% and 0.25% are different in a reasonable sized population. On the right-hand side, a little later study looked at the detection rate and found that in their series, not a huge series, but a reasonable number, they identified all of the Down syndrome, whereas the combined test was, I think, 79%. So as expected, there are many studies by this time in 2014, 2015 that showed those were the characteristics, and we know very well how well combined test works. So this was not unexpected. Let's look at the relevant lines back early on in 2012, 2013. There was general agreement that you should only offer this test to high-risk pregnancies, and ACOG defined high-risk pregnancies as things like advanced maternal age, an abnormal ultrasound, a serum screen positive, family history. And there were a couple of reasons for that. One is most of the studies done and published in 2011 through 2013 were in high-risk settings. And the test was expensive. But if you offered this test to, 100 women with a risk of 1 in 100, you might only have 2 positives, and 98 of the women would not need an amnio. Well, that saves good bit of money. And so the test cost was not as big a deal in the high-risk population as it might be in the low-risk population. Now, at that time also, there was not much information on screening in twin pregnancies. Microdeletions wasn't even being offered. Sex aneuploidy and fetal sex was available from a few laboratories, but the suggestion was do not offer it routinely, but perhaps you could offer it as an option. And that is something we'll talk about a little bit more. Now they've updated those. 2016, both ACOG and ACMG offered it, and they still agree that it's a good test in a high-risk population. There's kind of mixed recommendation in the general population. ACMG says, yeah, you should give it to everybody. You should offer it to everybody as one of their options if it's available through insurance or self-funding or whatever. And ACOG is a little bit less formal in that and says they can allow testing in a younger population. And then now they are saying optional sex aneuploidy testing is probably all right. Testing in twin pregnancies is less accurate, ACOG says, but doesn't say you shouldn't do it. And it'll be less accurate because when there's a dizygotic twin where one's affected and one's not affected, it's a little bit harder to tell them apart. When they're monozygotic, it looks just like a singleton pregnancy. And both recommend against microdeletion testing at this point. So what about high and low risk populations? I don't like calling it low risk. I'd rather call it the general pregnancy population. So as a first-line screening test, how might it differ than when you offer it just to these women over 35, ultrasound abnormality, etc.? Well, it's three ways. One is the epidemiological, that even if the detection rate and the false positive rate are the same, if the prevalence of the disease, how many Down syndrome per 1,000 pregnancies are there, the positive predictive value is going to change. So in the high-risk population, there are going to be many true positives to false positives, and that would be the positive predictive value, and it could be 5 to 1, 10 to 1. Depending upon just how high a risk population you're doing. In the low risk or the general pregnancy population, it could be that there's only about equal numbers of true positives to false positives because there's so few Downs in the general population. Perhaps in the first trimester only 1 in 400, whereas in a high risk population it could be 1 in 10. Also is the impact on test failures. When the test fails, so in other words, the sample was good, it arrived at the laboratory in time, they felt that it satisfied all the inclusion criteria, they ran it, and when they finished running it, they said, you know, there's not much we can do here. We didn't really learn much. That's a test failure. Now in the high-risk population, you know, the women have already been counseled about their high-risk setting. They've already probably been offered diagnostic testing. And so if the test fails, it's perfectly okay to just reflexively go back to the offer of diagnostic testing. You might want to repeat. You might want to do an ultrasound. But the options and the informed nature of the woman are quite different in the high-risk setting. In the low-risk setting, we do have to try and consider other options, like repeat testing, a serum ultrasound test, something else, because you can't just take a woman who's failed this test because, let's say, she's very heavy. We'll find out if you're very heavy, the fetal fraction's low and the probability of failure is higher. You can't just say, well, you need an amnio because you happen to be a bit heavy and the test failed. And then the pretest counseling. What do these women know and who's going to give it to them? In the high risk, it's genetic counseling, a genetic specialist, almost always at a maternal fetal medicine unit or at a PDC. In the low risk, we don't have enough genetic counselors. I worked out once that every genetic counselor that's going to be graduated in the next 10 years would be needed to give a half-hour counseling to about 2 or 3 million women that get prenatal screening in the U.S. So that's just not going to happen. So in the low risk or the general pregnancy population, the primary care providers are going to have to do this. And that's what our study was kind of about. So let me just also say that the study that we're doing is a clinical utility study. Validity studies are the studies that determine, well, what's the detection rate? What's the false positive rate? So those two earlier high-profile studies I showed you, they were really clinical validity studies because women never got the test results. We have no idea what they did with the results. There was no education because the women were just giving a blood sample. They were acting on the combined test results. So the clinical utility study is designed to be employed in real clinical practice. So the patients are informed about the testing option. Now, as the primary care providers have to talk to them about cell-free DNA testing. The results are returned, and the patients make decisions on it. And there are other things we can study here that you can't study in a validity study, like the education, knowledge, uptake rates of testing, and what did the patients decide to do when they had, for example, a positive screening test or a test failure. So as that is into now the DNAFirst study, the paper is quote is on the bottom. Women and Infants designed the study. It was funded by Natera, and they provided cell-free DNA screening at no charge. That was to simulate what it might be like a few years later when insurance might cover this. In Rhode Island, at least, where the study was done, there's no barrier to getting an integrated screening test or a first trimester combined test or a quad test. If you don't have insurance, it's going to be covered by the hospital. So we were trying to simulate the same sort of condition there. But all the analysis, interpretation, and reporting was ours at the hospital. So what were our goals? It's a utility process-oriented study. I just informed you what that was about. And the aims are really important here. We wanted to introduce cell-free DNA screening as the first line of prenatal Down syndrome screening offered by primary obstetrical care providers to the general pregnancy population. And you can see kind of the list of things that we were concerned about, the patient materials, making sure the providers knew what they were doing. We did surveys. We wanted to look at the optional detection of sex aneuploidies. So here is one thing that we think is really very important, is to get unbiased educational materials, not marketing materials, but educational materials. And we went through all the professional organizations' recommendations for what should be in that material. That's what was included, as well as a description of the disorders that were being screened for. It was done at an 8th grade reading level. We used focus groups of pregnant women to refine it. And then it was assessed by suitability of assessment materials, SAM criteria. And that's important. Imagine you have a really good material and you print it in light green letters on a yellow background, so nobody can read it. It's that font Arial of 10. So the suitability assessment has to do with many things other than just content. How does it look? How can it be read? So we approached the providers. Rhode Island, of course, is a very small state. The providers are pretty centrally located, quite a few large practices. We went to the 7 largest OB practices approached. 2 of them said, well, we're not interested because this doesn't follow ACOG guidelines. Remember, this was in 2014, when ACOG was still saying you should not screen in the general population. And they said, oh, it's just going to be too complex and it's going to mess our practice up, and they said no. But 5 said, sure, we'll participate. So those 5 large group practices all received in-house training. They ended up enrolling over 80% of all the samples. And I'll leave the next one. They all exceeded screening in the previous 6 months to a couple of figures that are going to come up now. So let me just describe this figure to you first so it makes sense. So across the x-axis is the week of enrollment. Now we knew, based on the last 6 months of screening these practices, we knew how many women they sent per week, the average number. And so on the y-axis, you'll see the ratio of testing, DNA over historical. Almost all of ours were integrated. So you could think of this as what's the DNA rate compared to their historical integrated rate. And if it was 100%, imagine drawing a horizontal line at 100%, that would say, the DNA is just the same as what their historical rate of giving screening tests were. So let's look at the first laboratory. So the first laboratory, you see, well, they started right up in week 2, perhaps, with a little dashed line. They started at only 25% or so of their target, but by week 6, they had already crossed the 100%. So at week 6, they already had more women being screened with cell-free DNA than they historically had sent as screening tests. And you can see, although it's jagged, it's certainly systematically above the line, and in fact, about 30%. So they actually screened this group practice, screened 30% more women than they had historically screened. Now, where did they come from? That's a good question. They weren't a lot of women aged 35 and older who decided not to have an amnio and to have screening instead. The rate of women over 35 was not much higher in our study than it was historically. So we believe that these were new women who were not being screened with the integrated test before because they had heard stories about too many false positives and so on. So we think these were new women being screened. Here were 2 more practicers, 2 more early adopters. You can see again very quickly here by the 3rd week. Not so quickly here. It took them almost 3 months to surpass the 100% level, but eventually they ended up at a pretty constant rate of 13% higher and 14% higher. And we'll just call those the early adopters. And how about the last 2? The last 2, you see, really waited quite a long time to begin. They wanted to see how did the other 3 practices fare before they started. And once they started, they just jumped right on the bandwagon. And you can see the 2nd week or about the 4th week, they were already either 40% high or 8% high. So all 5 of the large laboratories where we had enough reference data enrolled many more women than they did historically in the previous 6 months. So let's look how some of these study characteristics changed over time. So here we're just going to go by month, by 2-month intervals, first 2 months of the study, second 2, third 2, 5 to 6, and so on. The providers you can see grow steadily from 27 providers to 72 providers. So these would be physicians, nurse practitioners, midwives. Numbers of screens in 2 months, see it's again steadily growing from 265 to 777. The turnaround time for the test didn't change much. Now these are, it's the median turnaround time in days, and we don't count business days or whatever, but it's from the day the sample was collected until the day the report was sent to the provider. And the test failure rate on the bottom line is interesting. This laboratory had a relatively high failure rate, but in the first 2 months, 9.1%. This laboratory allowed samples at 9 weeks, and we felt there were just too many failures allowing samples at 9 weeks. So we asked our providers, why don't you wait till 10 or later? And you can see in the next couple, 4.1%, 3.0%. Then another little spike up to 7.1%. That was acknowledged later as a reagent issue in the laboratory, and then came back down to under 5%. So things did change over time. So how old were the women in the study? 2,685 women wanted to be tested. They averaged 31 years of age. 79% were under 35 years, 21% over 35 years. That's the population average in Rhode Island. The median week of collection was 12. They went from 9 to 31. So there was a very late suspected case that they just wanted to do cell-free on, and we did. But only 1.6% of the population had a sample after the usual screening window of 20 weeks. You can see the distribution of race, ethnicity, and indication for testing. 88% said this was my first screen. 10% of the providers said, well, she's over 35, I'm going to call her AMA, but it still was her first real test. There was no biochemistry or ultrasound done. A very few, 2%, had some other sort of indication. So what happened in the testing? So 2,691 women said, I want this test. 19 times that was not possible. 4 had insufficient sample volume. In other words, they're supposed to send 2 4 ml tubes. They sent 2 2 ml tubes. Well, that's not enough to do the test. 1 sample got damaged in shipment, and then another 14 samples were in a single shipment to the laboratory, and it got lost in the mail. And by the time it got to the laboratory, they were too long. And so 13 of them actually sent another sample and were tested. But unfortunately, you don't want to have these kinds of mix-ups, because 6 of those women who said they want to be tested ended up never sending another sample. And so 2,685 women were tested, but 4 of them failed one of the inclusion criteria. The material specifically says don't send twins. There were 3 unknown dizygotic twins. It specifically said, since this was a SNP-based assay, the mother and the fetus have to be related, and so one woman, it turned out, had a donated egg, and so those 4, although they were run, the sample didn't satisfy inclusion criteria. And so 99.6% of the women who started actually got a test report. It could have failed, but they went through the testing process. So what happened? So here are those 2,681. And let's first just look at the screen positives on the left-hand side. So out of 2,681, there were only 16 screen positives for the common trisomies, 21, 18, 13. 16 out of 2,000, almost 2,700. There were 9 positive for 21, 7 were true positives, 2 false positives. You can read that. 3 18s, all true positives. 4 13s, 2 true positives, 2 false positives. You work out the predictive value. There were 12 true positives to 4 false positives, which is a 75% predictive value. So 75% of the time in a low-risk population, a positive was a true positive. There were only 4 false positives out of the 2,681, or 0.15%. So very uncommon, less than 2 per 1,000. It's a very low false positive rate. I didn't put the detection rate there because you see the little middle of the diagram, no known false negative trisomy 21, 18, 13. We checked our cytogenetics records at the hospital for newborns and anything else that might have come in. We asked the providers to tell us if there was the birth of a Downs, and we checked specialty clinics for any newborns with Down syndrome. And we found none, but we're not convinced that that was necessarily meant 100% detection rate. So let's just put that in context with some of the other tests that we know. So on the first line is the old age of 35 or older. It should be a greater than or equal to. Age 35 or older at the time of delivery. Nowadays, that ends up detecting about 50% of all Downs, which seems pretty high, but 20% of the women are over age 35 in the U.S. So the positive predictive value, assuming a first trimester prevalence of 1 in 400, is only 1%. And 1% means out of 100 women, only 1 of them is going to be a true positive. So you do 100 amnios to find 1 case. How about the first trimester combined? Well, you see that's 85% detection for 5% false positives. That still isn't great. It's 4 per 100. Second trimester quad's about the same thing, 4%. The integrated or sequential, a little higher detection and most interest, a lower false positive rate, has a 10%. So now maybe 1 in every 10 positives for Downs is a true positive. And then I just say a generic screen looking at the literature. It's a 98 or 99% detection, and the false positive rate's about 0.2. That comes up to about a 60% positive predictive value. These are all in the general pregnancy population, nothing high risk here. About 1 to 1, about 50% of the time they're true positives. In ours, we added the 18, 13s, and 21s together. We don't know what the detection rate is, but you can do the positive predictive value without that, and our false positive rate was a bit lower, and we ended up with that 75%, which I showed you, which means 3 out of 4. So 12 of our 16, or 3 out of 4, were true positives. That's pretty good performance. Now, what about sex chromosome testing? Well, 2,685 women. There were 3 monosomy X's. 2 were IUFDs, but confirmed. One was a spontaneous abortion. So as you know, monosomy X, a large portion of those identified in the first trimester are destined to be lost spontaneously, and that's certainly what we found. Now, what about other things? Well, we found one XXY and one XYY. Both were counseled. Both decided that they were not going to have diagnostic testing. They both understood that there were some sort of treatments available, hormonal treatments that might change the outcome a little bit, but they could wait until delivery, or they could wait until the child was a few years old. And you see one of them confirmed post-delivery, the other one just declined testing, but they understood that it might be worthwhile doing it. 2,370 got XX or XY, male or female. We don't know of any incorrect calls, and another 70 just failed the sex chromosome testing. But you really have to consider sex chromosome testing as an add-on. It's really not a good target for a prenatal screening test. But how else? There's really no other way right now to identify sex chromosome trisomies before birth or before treatment is indicated, other than prenatal screening right now. Now, what about those 16 screen positives? What did they do, the 16 trisomies? All of them ended up going to our prenatal diagnostic center and saw a genetic specialist. 12 of them chose prenatal diagnosis, an amnio or CVS and karyotype, 3 false positives, 9 true positives, 7 terminated. 1 was spontaneous, was going to be continued and spontaneously lost. Another was continued and was a live birth. So that's pretty expected. And then the 4 who did not choose prenatal diagnosis, 1 false positives, 3 true positives, 2 diagnosed at birth, 1 IUFD that was confirmed. Now let's look more at the failures. So now we're not looking at screen positives or screen negatives, just the right-hand block that shows the initial failures. 150 of them, 5.6%, quite high. Most of them were complete failures. In other words, you didn't get anything about 21, 18, or 13. There were 10 partial failures where it might have given you 21 and 13, but not 18, so on. So what happened to these? Well, 65 of them got a repeat cell-free DNA, and it was negative. There were no positive repeat cell-free DNAs. So 43% of them got a confirmation that, now that you sent us another sample, it seems fine. We offered them to have a serum ultrasound screen. So we actually collected a serum sample at the same time we collected the plasma. And if the test failed, we did the best next test. So if they had an NT, we would run a PAP-A and an HCG and give the physician the option, the provider the option of a screening test, a serum screening test. And 54 chose that. They said, gosh, we've been doing that for the last 10 years. That's a pretty good option. 13 declined any testing. 9 had a positive serum ultrasound screen. All ended up being negative. 4 had a pregnancy loss. Maybe there was a Downs or an 18 in there. We can't tell, which is why we don't want to give a detection rate. And 5 are just lost to follow-up. So the majority either got a negative cell-free or a negative serum test, 109 out of 150. Going on. We also did patient and provider surveys. So let's see what happened there. So we did a validated patient survey. They had given permission on the laboratory form to be contacted where they would give verbal consent. You can see they had to be 18, between 10 to 20 weeks. We wanted the provider to not be on their first day of providing information. So we said the provider had to have 2 months of experience. And they had to be a person a woman, a pregnancy who had no previous screening. Almost none of them did, but we just made sure of that. So we ended up having to contact 140 women for this 15-minute phone interview by a certified genetic counselor. 27 women we could not make contact. Phones were out of order. They had to give their phone number as well and apparently changed it. 113 women we actually contacted. 13 of them did not want to do the survey, but the remaining 100 women did. And of the 72 providers who actually finished the study, we represented 45 of them. So this is a broad range of providers offering information to these women. So some of the things we asked to everybody was, how did you hear about it? What do you understand? Are you satisfied? What did you do? Do you remember asking about sex trisomy testing? And we also did subset questions. I can't show you all of this, but you can look at the paper and find that. Some of the women we chose because they had a serum screening in the last year in a previous pregnancy, and we wanted to have them compare what was it like to have an integrated test versus a cell-free test. And then we also over selected for those who had test failures to see whether that really bothered them or not. Here are a couple of things. So who did your pre-test information? Who provided this to you? And our wonder was, is it the provider, or is it the a nurse practitioner, or is it whoever happened to be there on that day? And it turned out that 55% of them said that the physician or their certified nurse midwife, which is relatively common in Rhode Island, actually provided the information, and 40% said it was an office nurse or dedicated educator in the office. And so we think that's pretty good. There are 5% who said something else, but not terribly important. How long did it take? Here's another thing. A genetic counseling session is usually a half hour or an hour, and in a busy schedule, you simply can't do that. So 36 said less than 5 minutes, and 39 said 5 to 9 minutes. And so you're in the 70 to 80% range under 10 minutes. Some obviously were 10 to 15, and there were a few that spent as much as 20 minutes, but rarely more than that. Did you have enough time? So regardless of how long, did you 95%? Yeah, I had enough time. That was fine. Did they answer your questions? Yep. Did the office staff make you feel the testing was optional? Was there any perceived pressure? We thought this was an important one, and we don't have control over this really, but 99%, only one did not feel that it was optional, that it was not conveyed as being optional. So we're reasonably happy with that. No education is going to be perfect, but let's get on content. This is one that a lot of surveys use to determine whether the women understand that this is not a perfect test, that you would have to follow it up with a diagnostic test to be sure. And almost 70% knew the test could not tell for certain if the baby has Down syndrome. So again, this is being presented from the primary care provider to a low-risk pregnant woman, and 69% of it got it right. That doesn't, you say, well, shouldn't it be 95%? Well, yeah, you'd love to have it 95%, but if you compare this to some other surveys where there's actually even a genetic counseling session for an hour, this is reasonably good. 98% would recommend the test to friends. 95% would say they'd have it in their next pregnancy, kind of common. Now, sex chromosome testing, you would think, it was optional in our study, so you would think, did women actually remember that they had to choose that? They had to actively check it off, or their provider check it off on the enrollment form, or they would not get fetal sex and sex chromosome testing. Well, 88 women remembered, or 86% of the women, which turns out to be should be 86 women. I don't know. Among the 88 women having such testing, 68% wanted to know the fetal sex. You, I'm sure, know that that's one of the questions about whether you should offer sex chromosome testing, because all the women want to know is what the fetal sex is. Well, some do, but not all. 59% just said, well, I want as much information as I can get. 42%, I don't know why they chose this, said, well, it was at no charge. 13% actually expressed concern about sex chromosome aneuploidies, relatively low percentage. But I'm not so worried about a large number of women feeling that they want to know the fetal sex, because think about this. They're going to find out with, some at the NT measurement, certainly others at the later second trimester. So although this is a little earlier and far more reliable than early ultrasound, it's not like a lot of them aren't getting this information early anyway. So among the 12 women who did not accept sex chromosome testing, interestingly, 2/3 of them said they didn't want to know the fetal sex. Well, of course, providers can withhold the fetal sex if the couple does not want to know. So this isn't the greatest answer, but that's what they said. Now, how about the providers? We also asked the providers information. Well, they are busy. Only 33 of the 72 providers responded. 21 physicians and 8 midwives. Among the 21 physicians, 90% said they personally presented this test. And they said it took 6 minutes, which jives very nicely with what the patients reported. About 40% less than 5 minutes, about 40% 5 to 9 minutes. So that probably was about right. And they gave the range from 3 to 15. They thought their staff was adequately prepared. Again, we went in and gave them a little 1-hour tutorial on what to expect and how to talk with the women and the educational materials and our support staff. The providers here said they felt between 60 and 100% of the women they talked to accepted the cell-free DNA. Oh my, and NIPT snuck in there. Accepted cell-free DNA screening. And they said that the reasons these women accepted the test, 90% for revealing fetal sex. That differs from the women. The women either are not admitting it or it's not as strong as the providers think. But 42% said, well, it's just better, earlier, more accurate results. They liked the ease of offering and test performance. The ease of offering is just, we're doing integrated, so you have to schedule the NT scan, schedule the first trimester blood draw, get them back again, explain the results. This is much easier to do. And they liked the low number of positives. It's much nicer to deal around. What were they concerned about? They did not like test failures. Test failures were a bother to them. They really wanted a test that more often gave results. They didn't like the turnaround time because they're used to a 1 to 2 day turnaround with serum testing. And they were worried about what happens when the study ends and these tests are not free anymore. Now, all good concerns. So a summary then, this was the first utility study that provided evidence that primary obstetrical care providers can effectively offer this testing in the general population and fit it into their routine practice. So, and as we showed earlier, they actually had a higher uptake rate than they had in the previous 6 months for screening. In general, the women understood what was going on and were satisfied. The false positive rates were as low as expected, and the positive predictive value was much higher than it is for any of the other current technologies, although the failures are a bit of an issue. The overall conclusion, clinical validity studies have shown cell-free has much higher detection with very many fewer false positives than any of the serum ultrasound screening, 90% versus 5% or so. Screen positive tests will be confirmed because we know that occasionally the placental material that we're testing with cell-free differs from the fetal genomic makeup. Professional societies have updated the recommendation that it's now allows or recommends, depending upon which of the two you would use, cell-free DNA in the general pregnancy population. We showed that with adequate education and support, primary care providers can do this, can do a good job of educating, not a perfect job, but a good job of educating. They know what to do with a screen positive or a failure or a screen negative, and it does not have to be offered solely through genetic counselors. And lastly, they were able to integrate it into their daily routines, and we're really pretty satisfied in the performance. I'll just leave my acknowledgments up there, and that's the end of the presentation. And I thank you for your attention.
And thanks to you, Dr. Palomaki, for an excellent presentation, and thanks to the audience as well. For any questions, please contact the Medical Affairs team at Illumina.